Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Welcome to the American Academy of Orthopedic Manual Physical Therapists podcast. My name is Leanna Blanchard. I am very excited. Today we have Thomas Bilterys, who's coming to us all the way from Brussels. He is with us to talk about a paper published in 2021 in the Journal of Clinical Medicine, for which he was a co-author. The title of the paper is The Association Between Sleep and Chronic Spinal Pain, a Systematic Review from the Last Decade. Thomas received his Bachelor of Science in Rehabilitation Sciences and Physiotherapy from VUB in Brussels, as well as his Master of Science in Rehabilitation Sciences and Physiotherapy from VUB with a focus in manual therapy. Most excitingly, he recently passed his PhD oral defense for his Doctor in Health Sciences degree at Ghent University and Doctor in Rehabilitation Sciences and Physiotherapy from VUB. His thesis for his PhD was on understanding insomnia in chronic spinal pain, and he is also a member of the Pain and Motion Research Group. So first off, thank you for joining us, and a huge congratulations for passing your oral defense.
Thank you very much. Also, thank you for having me here today. Eager to talk about the project. I'm happy to be here.
Very excited to have you. So I thought we would talk about, just starting off, a little bit about what was the inspiration for this project or this manuscript. Why did you decide to look at this?
So we actually were about to start on a project about chronic spinal pain, so neck pain, back pain, and insomnia, specifically for the treatment. So we were interested if we add treatment like cognitive behavioral therapy for insomnia to the current treatment approach, if there would be an improvement, like an added value of the treatment itself. Um, and to prepare, we searched in the literature and we found the study, the systematic review of Kelly et al. It was a bit older, and there was already some new studies available. So we thought, yeah, we can actually do an update of the literature and build further on that. That was the start, actually, of the article.
So it sounds like you're really trying to set up the next project for success and making sure that you've got good data to pull from.
Yeah, we actually already started with the project, and the data collection of the project is now completely done. So now we're analyzing the data and preparing it for another publication, actually. So soon there will be a publication about the combination of CBTI and the current treatment approach for chronic spinal pain patients.
Very exciting.
Yeah.
When that comes out, maybe we'll get a chance to talk about that one too.
Yeah, sounds good.
So I noticed that you and your group made the decision to go beyond just looking at chronic low back pain and to include neck pain in this review. Can you tell me a little bit about why that decision was made?
Yes. If we look at the literature, chronic spinal pain, chronic neck pain, and chronic back pain, we can see most of the studies are mostly about chronic back pain. If we look at the sleep studies, so they include mostly subjects with chronic back pain, but there are also some studies with neck pain. And we wanted to get an overview of chronic spinal pain in general. So it was logical to actually include neck pain, and if necessary, could always like split up both and interpret both separately. And in the end, if you look at the article itself, we always made clear that for the reader what the association, the investigated association, and which population it actually was. So it should be clear whether it was in chronic neck pain or chronic back pain patients. But we wanted to include everything of chronic spinal pain, so also neck pain and also back pain.
Yes, that makes sense. And I did find it to be very clear when I was reading through the paper, which was more related to chronic back pain versus neck pain. And I think it's an interesting addition too, because clinically speaking, I've often seen patients that have comorbid back pain and neck pain. It's not always just one or the other. So I think it was a nice decision to bring in both and look at spinal pain as a whole.
Yes, that's true. There is most of the time there is an overlap in chronic neck pain and back pain. So you can see that most patients do also have both. Not always, but you can see most of the neck pain patients also often experience back pain and vice versa.
Yes, certainly. So I appreciated the variety of measures that were used for assessing sleep clinically because I think, I'll be honest, in my own clinical practice, I don't think I'm doing a very good job of really assessing sleep beyond asking my patients, hey, how are you sleeping? So I'm curious if you can tell us about some of these measures or some of the differences between them or how they would or wouldn't be useful clinically.
If we look at what could be useful for clinical practice, we can more or less set some criteria. We want actually to have measurement tools that are fast, easy to use, are valuable, so they measure what they want to measure, and low cost. So it's also easy to use and implement for everybody. Now, if we look at the measurements and the study included in the systematic review, we see that most of the time questionnaires are used, which is also very logical because questionnaires give an idea of the subjective experience, which is also more related to the sleep complaint of the patient. We can also measure objective sleep, and that certainly has its value too. And if we look at literature, the polysomnography measurement, which is usually done in the sleep lab, but we can do also home-based polysomnography, is a golden standard to measure sleep, but it does not really reflect the sleep complaint of the patient. But nevertheless, it's very valuable to identify the other possible sleep problems like sleep apnea, which we cannot really treat, but we should be aware that they can happen. Now, back to clinical practice, the most used measurement tool is questionnaires. If we look at them, there are several variations. Also in the studies, you can see there are even study-specific questionnaires used. And so we can pick several questionnaires that we want to use, but it mostly depends on what you want to use the questionnaire for. So if we look at it, we can use it to measure the current state. We can use it to measure the progression, but also like the content of the questionnaire is important. What do you want to measure? Is it sleep insomnia severity? Is it a sleep quality that you want to measure? So it really depends on what you want to measure. But I think for treatment itself, because you can use questionnaires also to implement it in your treatment, one important aspect is like the sleep perceptions, the sleep beliefs of the patient. Because often the perceptions of a patient with sleep problems are not realistic. And with the questionnaire, the DEBAS, it's called, is dysfunctional beliefs and attitudes about sleep. That questionnaire can be used to identify those beliefs that are not realistic, those attitudes and thoughts that are not realistic about sleep. For example, some people do believe they have to sleep 8 hours or more to function well. Not all people need that amount of sleep. And if they see, for example, their partner sleeping for a longer time, they might start worrying about their own sleep. And being busy with sleep actually most of the time results in the start of sleep problems. And they might create their own difficulties to fall asleep because they are so busy with sleep. So even if those expectations are not realistic, we should be aware of that, and we could ask about them, and then we can reflect them and try to explain how sleep works and try to address their sleep perceptions which are not realistic, to reassure them that it's okay, that it can be that you wake up a little bit, but not necessarily has a large impact on your functioning and on your sleep in general.
Is it safe to say, and correct me if I'm wrong, but is it safe to say that sometimes it's quality over quantity when it comes to sleep?
If you look at patients, some patients really think they need more sleep, while most of the time it's the quality that's the most important. If you feel well rested, it's better than if you sleep a lot but you wake up and don't feel refreshed. So indeed we try to prioritize the quality instead of the quantity, and some patients think they need a quantity while they actually have the quality, but just because they want to reach the quantity, their quality decreases because they have longer wake periods of their time in bed. So they're just in bed trying to sleep, but actually they already reached the needed sleep and they have the experience and the feeling they can't sleep well. That sometimes happens. That, yeah, we need to be aware of that, and we can reassure the patient and try to let them experience and let them know what real sleep is, and that sleep also can change over time. Like it's normal if we get older that our sleep is lighter and that it's a bit more fragmented. Everybody experiences that, but some people compare their sleep with when they were sleeping at a younger age, and naturally it will you will have lighter sleep over time.
It's
So
an interesting opportunity to set expectations with our patients too, I think.
yeah, true,
Yeah.
true, true.
What was the name of that? The sleep attitude scale that you mentioned?
Dysfunctional beliefs and attitudes about sleep. That's the name of the questionnaire. I wouldn't just let the patient fill it in and you look at it, but really discuss it with the patient and talk with the patient to really know what the patient is thinking and what their thoughts about. So you really have an idea about it.
So you're really using it as more than just a measure, but as an opportunity for conversation and education with your patient.
Yeah, that's true. Yeah, and we still have other measurement methods. Like another measurement method that was used was the actigraphy or ActiWatch. So it's actually some sort of activity tracker that we then use to have an idea of the sleep wake pattern. And actually, while it can be useful in clinical practice, we also have to keep in mind that patients might start focusing on it and actually again focus on their sleep, and the device might you have to realize that the device actually measures physical activity. So if a patient lays down and it sits still, it's likely that it measures inactivity instead of sleep periods, but it still represents a sleep period. So it might not always be that accurate. And also sometimes we have to think that objective and subjective sleep is not always the same. So if the patients experience that they don't sleep well subjectively, but the device gives it positive, that's a good thing, because then patients is like, maybe I did sleep better. But it can also be the other way around, where the patient actually doesn't have any sleep complaints, but the device just shows, oh, you didn't sleep well, and then the patient might start worrying about their sleep, and then they again can start actually have more sleep difficulties and experience more sleep difficulties just because they are more busy with it.
Yeah, so if you're using something like the ActiWatch, or even these days, patients can track their sleep using. I know Apple Watch is doing things with sleep tracking, and there's other kind of over the counter sleep trackers out there. And I think it's a good point to be aware of if there's a disconnect between what that hopefully more objective data is saying and what the patient is saying, then being prepared to have that conversation with your patients and reassure them as needed, right?
Yeah, if their experience is all right and they felt like they slept well, I would just reassure the patient that it's okay and that the device might not be that accurate. But in general, if you look at the accuracy of such devices overall, it's actually pretty good, and we can use it to have an idea of, yeah, the sleep wake pattern and really the rhythm, if the patient has a stable sleep routine or not. You can see, for example, with people that they most of the time in the weekends they go later to sleep, and they have to actually reset it for to prepare for their week, and then you can see it shifting in the weekend and back to normal in the week. So yeah, it's interesting to see those differences and changes in sleep wake pattern, and it definitely can help also for the treatment to stabilize the sleep wake pattern to have a more condensed sleep period. So it definitely can be used in practice too. Another thing that is often used for sleep treatment and not so much in physiotherapy practice, but definitely can see it's being used in the future is a sleep journal, where the patients indicate when they go to sleep, how long it takes for them to fall asleep, how much they experience their wake periods, but also other factors and aspects that might be important for the sleep, like alcohol use, when they have their last meal, if they have snacks before they going to sleep, if they stand up during the night, such things can be registered with the sleep journal, which also gives valuable information. Yeah, for the polysomnography, like the sleep lab study, like I said, it's very high cost, and it might not be that useful in physical therapy practice. But if you expect that there is an underlying sleep problem like sleep apnea, or you see you use a sleep treatment, I would say, and you see no improvements over time while you do expect some improvements, then it might be useful to say to the patient that maybe you could go to a sleep lab and do such a measurement with a polysomnography to check if there is an underlying problem or not. And most of the time, if it's sleep apnea, they are very easily helped with their sleep, and it improves really fast.
I guess I would have kind of wondered too, you mentioned that polysomnography is not as commonly used in physiotherapy practice, which I agree with. And I'm wondering if, with any of the outcome measures that we've looked at, any of the patient reported outcomes, are there ever indications just based on the answers that someone's giving you on those measures that you would want to refer them for a sleep study? Or do you feel like those measures shouldn't be used in a way like that?
I mean, most questionnaires are specifically for like one outcome or experienced sleep quality in general, but there are some questionnaires that are made especially for screening, but you could just do it also though, with an interview actually. And some things that you like, sleep apnea is the most common underlying sleep problem, and some things like if someone is relatively large, if the partner where he sleeps with says like, yeah, he has sometimes breathing stops when he sleeps, or the patient reports frequently awakening, even the partner says like he wakes up or she wakes up but very shortly, and he didn't even notice like there was a little wake up shock, but it looked like he kept sleeping, then you might think, yeah, that there might be some sleep apnea or something. Another thing that's relatively common is periodic limb movement. So limb movements very shortly after each other and actually wake up the patient. It's very shortly, and it results in unrefreshing sleep. You have a small test for it that you can do, but it's not so common. And we also have to think if those periodic limb movements, everybody has them a little, don't have them, but if someone is in like a stress period or has like deadlines, a lot of deadlines with work or something, or there's events happening like a newborn or something is happening, they often are a little bit more stressed, and then you also see in their sleep that those limb movements occur more than usual. So it can be that in that one time you test, the score is a bit high, but then after some time, when the person is in a more relaxed situation, a more relaxed period of their life, that the limb movements are much less, or even there are almost no limb movements during sleep.
So it sounds like really just getting a good subjective history, and especially in someone with chronic back pain or chronic neck pain, asking these questions about sleep is a really good way to determine, is this something that we can start to work on with them, or do we need to refer them as well for a sleep study.
Yeah, and also if you expect to improve, like you give them sleep treatments, you give them advice, you are really busy with their sleep, and you expect improvement, and there is no improvement at all, then you should refer them to, because most likely there's something else.
That was an amazingly robust discussion on the sleep portion, and I really appreciated that on both a professional and a personal level, quite honestly. But I'd like to turn the discussion toward the associations that were investigated in this paper. There were quite a few potential associations investigated, and I found a lot of these to be really helpful and interesting. So I'm wondering if you can maybe tell us which of the relationships were most significant statistically, but also maybe which ones you find most clinically relevant or most interesting for our listeners.
We have a variation of associations and studies, but what I think is important, and maybe also the main takeaway, if you look at chronic low back pain and chronic neck pain in general, when it's present and when it's not present in people, and you look at the insomnia complaints of the sleep disturbances, you can see that sleep disturbances are actually more common in chronic low back pain and chronic neck pain patients, which is logical. But you can see it clearly from the data. And if you look at the general chronic pain population, you also see the same results. So that's already a clear indicator. But then also the most investigated variable is actually pain intensity, which is also very logical. Yeah, if you look actually at all the sleep outcomes, you do see that it's related to each other. If we go more in detail, that's also, if you look in the general chronic pain literature, that's also what we see back. So it's confirmed. Pain intensity seems to be associated with sleep quality, insomnia severity, sleep disturbances, etc. And also the other way around, we see that it's related with pain intensity. If we have lower sleep quality, the pain intensity goes up. But when we compare it, like the next day, so if we have pain intensity the next night, we can see that it's related. But the relation with burst sleep and then the next day levels of pain is actually stronger than the relation with pain and then the next night of sleep. So in that sense, sleep seems to be the stronger predictor for pain than pain for sleep. So if we interpret those results and take it to the clinical practice, we can say, yeah, maybe we should have more attention for sleep, since we can see that sleep actually is a stronger predictor for pain intensity than pain itself is actually for sleep. Maybe it's more important than we initially thought.
I was reading this paper thinking it's a little bit like the chicken or the egg argument, which comes first. And so it seems like we're trying to identify that here.
Yeah, I don't think we have to look at it that way, but I think also if the two problems are there for a longer time of period, it doesn't really matter anymore which one was first. The thing is, it's there, and how can we tackle both the best way is the next thing we should look at, because it's definitely like a vicious circle where pain keeps the sleep problems there, and the sleep problems keep the pain. So it's definitely a vicious circle where the patient is in, and we need to break through that vicious circle to get the patient better, I would say.
Any other associations that you find to be particularly clinically relevant that you'd like to share?
Overall pain duration doesn't seem to have a large impact. We do see if the pain duration is longer present, like it's a very long time here. It's for plus 11 years. So really chronic pain. We can see that like on the scales of disability, dysfunction of the sleep quality index, we can see that those values also get worse. That's really on when it's really chronic.
So, kind of key points here are that sleep problems seem to be more predictive of pain than pain being predictive of sleep.
Yes, in general, that is the main takeaway, and also that that sleep problems are more common in those chronic pain patients compared to the general population. Yeah, I would say that those are the main takeaways, I would say.
And so, one of the points made in the discussion was that one of the limitations was felt that we weren't controlling for specific types of spinal pain, a facet dysfunction versus a discogenic pain. And I'm just wondering if you have any ideas or hypothesis on if the results would be different if you were controlling for that pain generator, or maybe by a dominant pain mechanism, for example, like the presence of neuropathic pain versus no neuropathic pain. Do you think that would have changed the results at all?
I do think, because if we look in general to the literature about chronic pain and sleep that is already available, actually the results are more or less in line. So I would say it doesn't change that much, but I do think there are other aspects that have like a more important are a more important aspect than when the pain is specific compared to non-specific. So that I do think there might be some differences. Like for example, when the pain is present for a longer time, patients tend to have predominant nociplastic pain compared to more acute cases where there's more a nociceptive component. Both nociceptive components can still be present in the longer chronic pain, and nociplastic components can also be present after a really short time. So there's some overlap, but still, if there's nociceptive pain, patients do tend to have like the aspect of oversensitivity, that they react very quickly to stimuli, which is not the same in more acute cases. If the nociplastic component is not so predominant, that's also not so the case, and it's likely that there is more variation and difference than we think there are in their sleep, and like it's now presented. So I do think there are some differences probably, but we have to look more into it in detail.
I think one of the things that was mentioned as well in the discussion is the benefit of also using quantitative sensory testing to assess that pain more clearly. And I wonder if maybe that would help better identify or classify dominant pain mechanisms. And then that could lead to better discussion of sleep within that category.
I think there need to be like more investigation about the underlying mechanisms, and especially also if we have different pain types, are there different mechanisms that lead to sleep problems, and the other way around, and also mechanisms that lead to pain if we have sleep problems, but also reinforce the pain with pain types are present. So I think there is still work for the future there, but right now we already have a nice insight and a nice starting point also for the treatments. But I do think there can happen more individualization and probably more adaptations to the current treatment approach of CBTI that is implemented and tried in several studies in pilot trials. There's certainly aspects that we can further investigate in the future, and then try to implement in the treatment of people with sleep problems and chronic pain.
I found very helpful in the discussion the overview of the overlapping mechanisms between nociplastic pain or pain in general and sleep, and how they are kind of inherently tied together. It's a good reminder for me, and I hope to any clinicians that are listening, that the sort of assumed relationship between pain and sleep is deeper than surface level. And I think it's more complex than just the I hurt so I can't sleep, or the I can't sleep so I hurt. And there really are things at a physiological level that are happening that underlie both of these problems.
Yeah, it's certainly good to have, yeah, the background knowledge and knowing there's more than just it's pain and I can't sleep because of the pain, or the other way around. I have sleep problems, and because of that I have more pain. It's more complex. There are more factors that are associated. I also think we in physical therapy practice we are moving to a biopsychosocial approach, and then right now I think it's a good idea to focus on different aspects, but we also don't want to look just at one aspect and focus on that. It's not because someone has sleep problems that it's the most important aspect with that person. There might be other aspects too that are as important. To treat chronic pain, it's actually a lifestyle change, and sleep is one of those assets that can help, but it's not the only problem. So we really have to think about other factors that also influence the process of feeling, experience, and pain.
So really, we're potentially doing our patients a disservice if we're not looking at all those factors and taking in the picture of the whole person. Any other key takeaways from your work on this project?
I would just say be aware that there are that sleep problems are very common, and it's possible that you don't have much experience in treating pain. But if the patient has clear sleep complaints, it might be useful to already start with the general sleep hygiene rules and try to implement that already. That's a nice start. And I can just say I'm pretty sure there are going to be nice studies in the future that try to implement the more sleep targeted treatment approaches in the general management of chronic pain. There are some nice pilot trials and reviews already. I just can say be on the lookout for the future. There is maybe I can give some references that people that are interested can read. There is a nice paper that gives a nice overview of useful treatment approaches for sleep in chronic spinal pain. It's called Sleep Disturbances in Chronic Pain, Neurobiology, Assessment and Treatment in Physical Therapy Practice. And that's a nice paper that gives a general overview, but it's really easy to read and also has nice examples. So really worth a read if you're very interested.
Excellent. That is much appreciated. We will certainly provide the link to this paper and any others that you would recommend in the show notes. You gave us a little bit of a preview of your upcoming publication, your upcoming work. Is there anything else that has you excited or about the profession or anything else upcoming that you'd like to share with us?
Yeah, like I said, I'm really excited for the work that's coming up about the implementation of CBTI and the physical therapy treatment. It was actually really an implementation of the treatment because we compared it to the usual treatment. It was about 18 sessions, and the experimental treatment was the same amount of sessions, the same duration. So it was really an implementation instead of an additional part. I think for the future, like I said, there will be more adaptations to the treatment for those more individualized approaches. I think that's something nice that we will look out for the future. Another aspect is like I said also, we have to look at a larger picture, the biopsychosocial approach. We will also look at factors like depressive symptoms because we can see that sleep problems are often go hand in hand with depressive symptoms, but also with anxiety. And we will also look at that. What is the influence if patients have more depressive symptoms? Are they if they are a little bit down? What is the effect of the treatment? Are there things that we can change to the treatment to potentially improve the outcomes of the patient? So we are definitely also going to look at that, and I think that's an interesting way forward. Another aspect that I'm interested in and that I'm also trying to get some things out is the measurement of sleep, because right now it's mostly based on subjective assessment, which is actually good because that's the subjective complaint of the patient. But I think it's also necessary to have like a easy to use objective measurement, which can be used in clinical practice, and to identify like the underlying problems, but also the potential discrepancy between objective sleep measures and subjective sleep measures.
And really then being able to combine those two things to create the best intervention, right?
Yeah, because right now I think also some people might have similar sleep complaints, but it might be that the objective sleep differs in those people, and we can wonder, should we treat those patients the same? Because most people arrive in clinical practice and you would do an assessment mostly based on the subjective complaints. And then we don't really know about the objective sleep. And it might be likely that there is a more efficient way to treat those patients, considering that these objective sleep might be a bit different. But those are aspects for the future, and we have to look more into it. I'm also working on a paper about objective and subjective sleep, and you really can see that there is a discrepancy between objective and subjective sleep. So it's not always the same, and some people do overestimate their sleep quality, like their sleep time, and some do underestimate it. There's really a large variation between persons. But in general, they think the sleep is worse than it actually is. But you also can see there's a large variation. So,
Well, it sounds like we've got a lot to look forward to coming out of your area of the world. I'm personally very excited to see some of the results of these projects. Thank you for sharing that with us.
Thank you very much for inviting me and talking about sleep and pain. I really enjoyed it.
Of course, I did too. We hope to have you back sometime.
Yeah, thank you very much.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.